This is chapter 33, recording number 3. There are 3 distinct stages of labor. Number 1 is the dilation of the cervix, 2 is the delivery of the fetus, and 3 is delivery of the placenta. The first stage begins with the onset of contractions and ends when the cervix is fully dilated. The first stage is usually the longest, lasting an average of 16 hours for a first delivery. The onset of labor starts with contraction of the uterus. Other signs of the beginning of labor are the bloody show and the rupture of the amniotic sac. The frequency and intensity of the contractions in true labor increase with time. The uterine contractions become more regular and last about 30 to 60 seconds each. Labor is generally longer in a prima gravida woman, a woman who's experiencing her first pregnancy, than that of a multigravida woman, a woman who's had previous pregnancies. A woman may experience preterm or false labor or Braxton Hicks contractions. You should provide transport for the patient. If true labor is occurring, you may need to prepare for delivery. Some women experience a premature rupture of the membranes in which the amniotic sac ruptures too early and the fetus is not developed or ready to be born. Your patient may or may not go into labor. If this has happened, you will need to provide supportive care and transport to the hospital. Toward the end of the third trimester, the head of the fetus normally descends into the woman's pelvis as the fetus positions itself for delivery. This movement down into the pelvis and the sensation that may accompany the descent is called lightening. Here's a graphic that shows you false labor, also known as Braxton Hicks contractions, versus true labor. This is provided in your book. You can go ahead and review it there. The second stage of labor begins when the fetus begins to encounter the birth canal and ends with the delivery of the newborn for a spontaneous birth. During this stage, you'll have to make a decision about helping the woman to deliver at the scene or providing transport to the hospital. Uterine contractions are usually closer together and last longer. Under no circumstances should you let the woman sit on the toilet. Part of having a baby, it feels like you have to take a big poop. And so oftentimes they'll say, well, I just have to go to the bathroom. But sometimes it's not going to the bathroom and they end up delivering in the toilet. So we really don't want to have them do that if at all possible. The perineum will begin to bulge significantly as the top of the fetus's head should begin to appear at the vaginal opening. This again is called crowning. The third stage of labor begins with the birth of the newborn and ends with the delivery of the placenta. During this stage, the placenta must completely separate from the uterine wall. This may take up to 30 minutes. So don't rush it. Don't grab on that cord and yank on it. Just let it naturally deliver itself. Preparing for delivery. Consider delivery at the scene when delivery is imminent, aka will occur in a few minutes, or a natural disaster, inclement weather, or other environmental factor makes it impossible to reach the hospital or safer just to deliver at home. If you don't have to deliver in the back of an ambulance, it's a lot nicer. The back of an ambulance is very small, very tight, confined quarters, not exactly ideal for moving around. So it might be safer and more comfortable to just go ahead and deliver at home and then transport mom and baby together. To determine if delivery is imminent, ask the patient the following questions. How long have you been pregnant? When are you due? Is this your first pregnancy? Are you having contractions? How far apart are they? How long do they last? Have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement, or do you feel the need to push? To determine potential complications, ask these questions. Were any of your previous deliveries by cesarean section? Have you had problems in this or any previous pregnancies? Do you use drugs, drink alcohol, or take any medications? Do you know if there's any chance you'll have multiple deliveries, aka twins, triplets, etc.? Does your physician expect any complications? And oftentimes a woman that's gotten regular prenatal care will know these things. If the patient says she's about to deliver, she says she has to have a bowel movement, or she feels the need to push, you should immediately prepare for delivery. If she says that she has to deliver the baby or she's going to deliver the baby, first and foremost, make sure you trust her. She knows more than you do in this situation. Otherwise, does she have an extremely firm abdomen? Visually inspect the vagina to check for crowning, and then do not touch the vaginal area until you've determined that delivery is imminent. Once labor has begun, it can be slowed or stopped if it needs to be. Obviously not by us in the field, but if we can get her to the hospital, they can. Never attempt to hold the patient's legs together. Don't let her go to the bathroom. Instead, reassure her that the sensation of needing to move her bowels is normal and that means she's about to deliver. If the decision is made to deliver at the scene, remember you are only assisting the woman in delivery. Your part is to help, guide, and support the baby as it's born. You want to appear calm and reassuring while protecting the woman's modesty. Recognize the situation is beyond your level of training. If there's any doubt, contact medical control for a decision to deliver on scene or during transport. Your emergency vehicle should always be equipped with a sterile emergency obstetric kit or OB kit, and it should contain the following materials: surgical scissors or scalpel, umbilical cord clamps, umbilical tape, a small rubber bulb syringe, towels, drapes, or sheets, 4x4s and or 2x10 gauze sponges, sterile gloves, an infant blanket, sanitary pads, an infant-sized bag valve mask, goggles, and a plastic bag. Patient positioning. The patient's clothing should be removed or pushed up to her waist, and pants and undergarments should be removed. Remember to preserve the patient's privacy as much as possible. Place the patient on a firm surface that is padded with blankets, folded sheets, or towels. Elevate the hips about 2 inches to 4 inches with a pillow or blankets. Support the head and neck and upper back with pillows or blankets. Have her keep her legs and hips flexed with her feet flat on the surface beneath her with her knees spread apart. Communicate with your crew and plan who will be responsible for caring for the mother and newborn after delivery. If the emergency delivery is occurring at home, you should move the patient to a sturdy flat surface or floor if she'll allow it. Track the progression of the delivery closely at all times. Put on a protective face shield and gown. As time allows, place towels or sheets on the floor around the delivery area to help soak up body fluids and to protect the woman and the newborn. Open the OB kit carefully so that its contents remain sterile. Put on the sterile gloves. After this, handle only sterile materials. Use the sterile sheets and drapes from the OB kit to make the sterile delivery field. Place one drape under the patient's buttocks and fold the other toward her feet. Wrap another drape behind the patient's back and drape over each side. Drape another sheet across her abdomen. And here's a picture. So just trying to keep her covered a little bit. For delivery, your partner should be at the patient's head to comfort, soothe, and reassure her during the delivery. If the patient will allow it, administer oxygen. It's common for patients to become nauseated during delivery and some may vomit. If this occurs, have your partner assist her in clearing out her airway. Continually check the patient for crowning. Some patients may experience precipitous labor and birth, meaning that it's faster than you would expect it to be. Position yourself so that you can see the perineal area at all times. Time the patient's contractions. Remind the patient to take quick, short breaths during each contraction, but not to strain. Between contractions, encourage the patient to rest and breathe deeply through her mouth. Observe the head as it begins to exit the vagina so you can provide support as it emerges. Place your sterile gloved hand over the emerging bony parts of the head to control delivery of the head. Continue to support the head as it rotates. Apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tearing. Be prepared for the possibility of the patient having a bowel movement because of the increased pressure on her rectum. Be careful that you don't poke your fingers into the newborn's eyes or into the fontanelles. For an unruptured amniotic sac, usually the amniotic sac will rupture at the beginning of labor or during contractions. If it is not ruptured by the time the fetal head is crowning, it will appear as if a fluid-filled sac is emerging from the vagina. The sac will suffocate the fetus if it's not removed. You may puncture the sac with a clamp or tear it by twisting it between your fingers. Make sure that the puncture site is away from the fetus's face and only perform this procedure as the head is crowning. Clear the newborn's mouth and nose using a bulb syringe if required by your protocols, and wipe the mouth and nose with gauze. Make sure that you squeeze the bulb syringe first, then put it into the nose or mouth and let it suck. If the amniotic fluid is greenish, notify the receiving hospital. As soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck. This is commonly called a nuchal cord. A nuchal cord that is wound tightly around the neck could strangle the fetus. Usually you could slip the cord gently over the delivered head. If not, you must cut it. Once the cord is cut, you must attempt to speed the delivery by encouraging the woman to push harder and possibly more often, because the fetus will now have no oxygen supply until it's delivered and breathing spontaneously. Once the head has been delivered, it usually rotates to one side or the other. This rotation places the body in a better position for delivery. The head is the largest part of the fetus. Once born, the body usually delivers easily. Support the head and upper body as the shoulders deliver. Do not pull the fetus from the birth canal by any means. The newborn will be slippery and covered with a white, cheesy substance called vernix. Post-delivery care. If the mother is able and willing, hand the newborn to her or place the newborn on her abdomen so skin-to-skin contact can begin immediately. Dry off the newborn and wrap him or her in a blanket or towel. Wrap the newborn so that only the face is exposed, making sure the top of the head is covered. Place the newborn on one side with the head slightly lower than the rest of the body. You can pick up and cradle the newborn. If the local protocols specify, keep the newborn at the level of the woman's vagina until the umbilical cord is cut. Always keep the head slightly downward to prevent aspiration. Wipe the newborn's mouth with sterile gauze pads as needed. Post-delivery care of the umbilical cord is important because infection is easily transmitted through the cord to the newborn. Once the cord has stopped pulsating, clamp and cut the cord. Evaluate the newborn for term gestation, good muscle tone, breathing and crying, and obtain 1-minute APGAR scores. Give the wrapped newborn to your partner to complete the initial care. You can give the newborn to the mother if she's alert and in stable condition. Delivery of the placenta. The placenta is attached to the end of the umbilical cord that is coming out of the woman's vagina. Again, your job is to only assist. The placenta delivers itself, usually within a few minutes of birth, although it may take as long as 30 minutes. Do not delay transport waiting for the placenta to deliver. Never pull on the end of the umbilical cord. Some bleeding, usually less than 500 milliliters, occurs before the placenta delivers and is normal and expected. Wrap the entire placental and cord in a towel, place them inside the plastic bag, and take them to the hospital. After delivery of the placenta and before transport, place a sterile pad or sanitary napkin over the vagina and straighten the woman's legs. You can help slow the bleeding by gently massaging the fundus of the uterus through a woman's abdomen in a firm circular kneading motion. You should be able to feel a firm grapefruit-sized mass in the lower abdomen called the fundus. Record the time of birth of your patient on your patient care report. The following are emergency situations. More than 30 minutes has elapsed and the placenta has not delivered. There's more than 500 milliliters of bleeding before delivering of the placenta. There's significant bleeding after the delivery of the placenta. If one or more of these events occur, transport the woman and the newborn to the hospital promptly. We'll go ahead and stop here.